It refers to the medical care and the support provided to women during pregnancy, all in an effort to ensure the well-being of both the mother and the developing baby. It plays a significant role in promoting a healthy pregnancy, detecting and managing potential risk or complications, and ensuring the best possible outcomes for both mother and child. A very warm welcome to our hospital. I'm Sherwood McCaskey. As always, I'm pleased that you have joined us. Interestingly enough, there is a special department here at our hospital, the antenatal department, that is dedicated to the provision of these services. Cheryl Homer Ellis is a registered nurse and midwife in this department. She walks us through the process, providing the steps the pregnant lady should take.
She discovers she's pregnant. She will go to a doctor, her GP, or a clinic, whether it be public or private clinic, and verify the pregnancy. The doctor would then refer her to our clinic, doctor or nurse. And at our clinic, we mainly see the high-risk patients. They come with a condition, or they may likely to develop a condition. It must be a referral from the mentioned areas. At the clinic, then the nurse, the first person the lady comes in contact with is the nurse, and she goes through the biographical data and various different histories, like obstetric history, which would be like if she's had babies before or if this is her first time. Then we do special investigations to get a baseline, like hemoglobin, blood group, certain sexually transmitted infections, and so on. And, well, go from there. We monitor her every 4 weeks, every 3 weeks, every 2 weeks, and then weekly until she then is, when she goes into labor, she then is seen by the nurse, the midwives on labor ward. After labor ward, having delivered, she will then be taken care of on the obstetric block. In antenatal clinic, our main focus is the pregnant lady.
But exactly what is antenatal care?
Antenatal is the care that a pregnant lady receives from the time she knows she's pregnant until she goes into labor. First thing I do personally is get to find out what they are thinking. What are your issues, you know? If I see a certain look, let's say they look afraid, you know, and I use my Bajan. I talk Bajan. I don't talk above their head. I don't use big words. And if I do have to use a big word, I will break it down, okay? And go from there, really. So investigating, assessing them, that's the correct word, assessing them, not just by what they tell me, but how they are looking that particular day would say to me what angle I should go at, for want of a better word.
You can appreciate that we are a tertiary healthcare institution, so most of our patients are here because they have some kind of challenge. So for those who are on the antenatal aspect, and antenatal will be looking at patients that are 20 weeks and over, we are looking to care for them depending on their conditions. So we can have patients that come in that might have high blood pressure, or can have anemia, which would be a low blood count. So it depends on what is wrong with the patient. We cater to the patient's needs accordingly. So everyone won't receive the same care. Everyone will receive care depends on what is wrong with them. And then once they're ready enough, they'll go home. If they come in labor, or what we would say in early labor, that person will be kept until delivery time. But as I said, care is provided depends on what is going on at that current point in time.
To show that it's not just the physical, because when you think of a pregnant lady, you think of a tummy and the diet and so on. But there was this lady, I was the person responsible for taking bloods, right, to send for investigation at the lab. And she sat in my chair, and she had looked sad. So I took the blood, and her husband was hovering, he was with her. And I looked at him, and I looked at her, and I said, "Are you all right?" And she said to me, "Come," she indicated, come closer. So I went in closer, and she said, "When you go outside, you just feel like the earth gonna open and swallow you?" I said, "Oh, is that what's happening?" She said, "Yes, the earth gonna swallow me." So I can laugh now, it may seem funny, but it wasn't funny then. I got up straight away. I said, "Okay, I had her notes, I had to document what I did. And I took them back to the doctor that had seen her, and I related to him what had just happened. And he said, "Okay, we'll admit her immediately." Because what was happening is that she was having prenatal psychosis. Right? We know about postnatal psychosis, but there's also prenatal. So then she was admitted. From there, she would be on the ward, and she would be seen by the appropriate doctor, along with the obstetric care.
Yes, all of that care is provided here at our hospital. Now, if you're thinking of becoming pregnant, here is some very good advice from the unit.
I had to advise someone who's, first of all, thinking of becoming pregnant. You should start looking after yourself from then. Don't wait till you're pregnant. Know that you want to become pregnant. In this day and age, research it, right? And get pregnant. Have fun doing it, because your psyche also affects your developing fetus. So be happy with this pregnancy. Get a partner that you can share this experience with, even if he's not going to be around, but he would still share in the experience. And of course, share after the baby is born as well. As soon as you know you're pregnant, get a doctor involved. Go and get it confirmed, and you can go privately, or you can do the public system. And yeah, the sooner you come with your pregnancy, the better. That gives us more time with you, more teaching can occur, and you understand what the outcomes are likely to be.
Very good advice indeed. The nurses continue the discussion by speaking of the importance of antenatal care.
I would suggest ladies coming for antenatal care because we can track your progress throughout the pregnancy. And if there is a problem, then maybe it's something that we can deal with, which would give us a better outcome, if not a good outcome. If you do not come to clinic, then there is the possibility of all these different things that the psychosis that I mentioned earlier, you know. The Ministry of Health provided us with special forms which we fill out. Like I said, it starts with biographical data. From the top, you do the Barbados ID, your hospital number, your name, address, different things like that. The next section deals with what we refer to as the obstetric history, how many times you were pregnant, and briefly state things like how far along pregnant you were, male, female, body weight, did you breastfeed, thing. Turning the page, you have the family history. So in your family, what types of conditions are there? And we would give a few. We have a few listed, and we'll go through those, okay? Sometimes they may add one that we don't have. Then there's your history. Do you have any previous surgeries? Do you have any conditions, asthma, high blood pressure, what have you? All right. Then we go into the investigations. are you anemic? How are we going to know that you're anemic, meaning that you're not getting enough iron in your diet? So we do blood tests to find out some things. Hemoglobin is one that we really keep our eye on. What blood group, blood type do you have? Have you been exposed to syphilis? Have you been exposed to gonorrhea, chlamydia, hepatitis B? Those are conditions that if we discover you have them, we can treat you. And by treating you, we also, our aim then is that the baby doesn't get infected with these conditions as well. There's rubella that we also check for, because if a lady has rubella, it can severely affect the baby. The fetus, I keep saying baby, the fetus, and may even result in intrauterine death, meaning that you would deliver a baby that's not living. We also check on HIV. We check if there's a strong history, discovered a strong history of diabetes, for instance, we can then do screening glucose test, which is also a blood test. From that screening test, it would tell us, do we need to do the other test to follow up? Because if that is abnormal, then we do a fasted glucose tolerance test, which is also a blood test, right? If you have negative blood, if your rhesus factor is negative, then we check, we do a test called the indirect Holmes test to see if there's been a reaction with your blood, and the fetus having the father's positive rhesus may cause a reaction, and antibodies to destroy one or the other. So we will do that as well, and that would be only if you have a negative. If you happen to know your partner, suppose you're positive, but your partner is negative, then we will do the test as well, okay? We find out things, social history, level of education. In terms of what type of house do you live in, how many bedrooms and stuff like that. Then we go into finances. Who looks after you? Are you working? Are you married? Your partner involved, right? In that section, we also take care of how, when you, as the Bajans would say, when you taking, how you can get to the hospital. Is there transportation at the home, right? After that, then we go into things like, do you smoke? Do you drink alcohol? Do you use illegal drugs? Have you misused prescription drugs before? Have you misused over-the-counter medication before? Depending on the answer, we will advise accordingly. Smoking, for instance, will deplete not only your oxygen, but also the baby's oxygen. Without enough oxygen, then the baby cannot develop as it should and may born with various complications from birth defects of various complications. And we kind of tell you what to expect at the clinic. We advise you to keep all your appointments. When you can't make an appointment, you will call and we can advise you over the phone. If you say, oh, I'm not well, so I won't be in, then what's going on? Right? Not well meaning what? And then we would say, well, I think you should get here. Even if you get here late, you get here, right? So there's that. After that, then you got these sections where they're seen by the doctor, having had their blood pressure and stuff done first. Because we would document that. They will see the doctor assess them and write their findings.
Caring staff members of the antenatal department here at our hospital, encouraging you to make very good use of their services. Now, in an attempt to make it as clear as possible, Nurse Homer Ellis and Scanterbury provide hypothetical situations to point you to the best possible patient care.
From the past medical history or family history, you would discover that we're saying she is diabetic and she became pregnant. So during this pregnancy now, most important thing, in my opinion, is that she monitors her blood sugars. So we'll make sure that she has a glucometer, which is a special machine for doing that. She would be given a form where she documents her findings, and she will bring those findings with her to clinic each time. And of course, the diet and exercise still plays a part if you are diabetic and pregnant. So we kind of emphasize those, even though they may have been adhered to prior to becoming pregnant. And then we keep an eye on the fetus, because being diabetic, the levels of the blood sugar in the bloodstream may cause certain things to go wrong with the fetus. So we keep an eye on the fetus as well, and this may be done by doing what they call ultrasound profiling when the pregnancy reaches, I think, about 28 weeks. This is not only for diabetics, but we're talking about diabetics. So yeah, basically what to look out for after the baby born, and how to proceed after the baby born as well.
And as I said, it depends on how the patient presents. So if I give you a scenario, I can have a patient that is newly diagnosed diabetic. I was just screened and it came back that my levels are high. I'll be admitted to our antenatal ward, or I should say the patient will be admitted to the antenatal ward, and then we will do a series of screening, meaning that we'll be checking the blood sugars, what we call fasting, before meals on morning, and then after every meal 2 hours, and see what the levels are like. And then depending on what the levels are like, the doctors, they do rounds every day. They will come and they will evaluate, and then go from there, and then we can start insulin, because most of the time, once you are diabetic in pregnancy, unless you can control it on your diet, you will be on insulin. Yeah?
Let's say she comes into the pregnancy with high blood pressure, but in most cases, you get what is known as pregnancy-induced hypertension. But we are saying that she came into the pregnancy knowing she's diabetic. She will be placed, if she was on taking medication, in most cases they are, those will be stopped. And then she will be placed on a drug that is safe for pregnancy, and her blood pressure, which is done at each visit for every antenatal patient that come to clinic. They come Mondays, Tuesdays, Thursdays, and Fridays. So before they see the doctor, they must have their blood pressure, their urine, and their body weight documented. And this is done with the hypertensive mom to keep an eye on the readings, to adjust the medication where necessary. Certain blood tests again that are done to keep an eye on certain chemistries, because changes in those chemistries will be used as like a yardstick to deal with any issues that are looking like they would occur.
Now it is delivery time. How do we prepare the expectant mother for delivery?
Let me give you a scenario. So a patient comes in for cervical ripening, what we call cervical ripening, IOL, and let's say that that patient is a diabetic patient. So you come in and you know that you're coming in for delivery. During that process of admission, we inform you why you're here, or even we ask you why you're here, so that we can know why you have come. What you don't remember, we fill in. So you've come to go to labor ward. You've come, this is what I expect. You're not in labor as yet. What we will do is make your cervix ready for delivery, what we will call cervical ripening. We use something called a urethral catheter, and that goes into the cervix and causes the cervix to dilate, what we call ripening. And once you're about 3 centimeters dilated, then you'll be transferred. What we call the induction of labor, as you would have heard me call it, IOL, induction of labor. And that, yes, I should have explained that earlier, induction of labor. So when you come over to the labor ward, then we give you artificial oxytocin. That's a normal hormone that is already in our body. For if persons like me go into labor naturally, my body will normally produce that, but because you're coming for induction of labor, we are giving it to you to initiate those contractions. And then for some patients, you can give it, and then you do the rest on your own. So when you come over here, is monitoring. You are given medication artificially, intravenously, so which means that we have to be monitoring you all the time. If you were doing it on your own, then we can do what we call intermittent auscultation or intermittent monitoring, because it's a normal process. But once you come from over the antenatal aspect to labor ward as the induction of labor, you will be monitored constantly.
Well, is that not comforting for the mother, knowing that you will be monitored constantly? Yes, that care is offered here at our hospital. This has been a look at the services offered by the antenatal department of our hospital. I'm Sherwood McCaskey. Goodbye for now.